Hey, welcome everyone. I'm Dean Elledge. I'm the number 2 here, also known as the Program Director of AEGD. Well, who's number 1? Well, we got 3 number 1s. I got Amanda Connor, first point of contact for the residence experience. Number 2, Anna Rada, face of the clinic. Number 3, Machen Johnson, the go-to for the DAs. Without them, doesn't happen. Why do I do this? As my wife says, and I tell her, I'm living the dream. Today, I recognize my residents. Today, we recognize my team. Today, we recognize the sacrifices of my faculty. Number 1, Dr. May, my assistant director and periodontist, has been here before me. He's the founding faculty of the program. Also today is a big day. 8 years of service, Dr. Randy Metzler, our go-to endodontist. He always gets to the root of the problem. So, Dr. Metzler, we have a gift for you today. The gift represents the journey through the rattlesnake pit, the journey through the poison ivy, and your journey with us. It's been a great experience with our gift. Our gift will take you to your next journey, your next path, the next fork in the road. It's been an amazing journey, Dr. Metzler. We recognize you today, along with the group. Thank you very much.
Good evening. Welcome to our graduation this evening at our WSU AEGD program. For those of you who don't recognize me, I'm Dr. Metzler. I'm our staff endodontist here at the program. You normally see me with a beer t-shirt on, but as proof of Dr. Elledge's persuasion, he talked me into wearing a tie today. I generally only wear ties at weddings and funerals, and that's not even a given. This is not a wedding, and I certainly hope it's not a funeral, but Dr. Elledge, thank you so much for 8 years ago calling me out of the blue, a busy afternoon at my private practice. My receptionist said, "You have a call from Dr. Elledge." Well, I didn't know who Dr. Elledge was. And he wants to talk to you about WSU's dental program. I didn't know WSU had a dental program. But I took the call, and as they say, the rest is history. Dr. Elledge introduced himself and let me know that we had a common friend, a fellow dentist that I had graduated with from dental school, and asked me if I would consider teaching here at his program. Having taught before when I was in the Air Force in a similar program and thoroughly enjoying it, it didn't take me long to say yes. And after touring our great facility, I was hooked. And 8 years later, it's time to say goodbye. So thank you, Dr. Elledge. Don't know what I would have done with those 8 years, but I thoroughly enjoyed it. I'd also like to thank all of the faculty and all the staff at the program, a couple in particular. I would like to thank Dr. Troiani, who I've spent just about every Thursday afternoon with the last 8 years. We've become good friends, and I think we made a pretty darn good team, and I hope the residents think so too. And I would also like to thank our lead dental assistant, Kathy Franks. She's been a rock for our program. She's been a help for me every time I ever needed it. If I needed help with assisting, if I needed to find out where a piece of equipment or whatever was, I could always go to her and I could always count on it. So thank you, Kathy. Thirdly, I would like to thank WSU, my alma mater. I graduated from here a long time ago, 1976. And I'm glad that I could give back some of the education that I got here, and I felt like it prepared me very well for dental school. I would also like to thank all of the residents that I have taught over the years. I've lost track, but I'm guessing there was probably 45 or 50 of them, and I've thoroughly enjoyed it. I enjoy teaching, and for the most part, it's been a very, very rewarding time. My 2 goals that I had when I started this program were to share some of my knowledge and some of my experiences with the residents, and I did accomplish that. The second one, I'll probably never know, but what I wanted to do was have a role in increasing the quality of care that my residents gave to their patients. And like I said, I hope that was accomplished. Lastly, I would like to say good luck to all the faculty, all the staff, and all the future residents. It's been a great ride, and I thoroughly loved it. So thank you. Good night.
Well, this is our gift our team has put together for Dr. Metzler, wrapped in endodontic tape. We have a PPE, of course, impromptu gift wrapping for Dr. Metzler. We'll start at the bottom. And what have we here?
Oh my.
We have a crooked stick, chewed up and chewed up by a beaver, right at the end with the beaver teeth. We have Dr. Metzler's face carved in the top. The middle of the staff is a rattlesnake wrapped around its stem. At the end is the poison ivy we talked about. The journey has passed, the twist, the turn, and complete with signatures and well wishes from the entire team.
Oh my gosh. This is great. This is amazing.
So will that hold you up as you journey your life's path?
I think I might be able to get by with this.
We're going to follow you on that path, and maybe we just walk out the door here, and
you can lean on me.
I can lean on you, buddy.
Okay.
It's been a great ride.
Thank you, guys.
Hello everyone, my name is Dr. Tommy Vu. Thank you all for being here tonight and watching. Today I'll be presenting on a topic titled Establishing Occlusion, Implant Supported Bridges and Dentures. So a little bit about me. I'm born and raised in Grand Rapids, Michigan, so way up north. I had the pleasure of going to the University of Michigan for both my undergrad and dental school career. I'm a big fan of Michigan sports, so you can usually find me here at the Big House on a football Saturday. In my free time, I love spending time traveling to different areas and going on hikes. This top right picture is a hike I did a few years ago in Canada. On the flip side, I have a big passion for movies. I always joke that I consider myself a big movie guy, but have a bad taste in movies. This summer, I'll be adding another 2 years to my Michigan education run by continuing in a pediatric dental residency. However, I'm very grateful for my time here at Wichita State. So today I'll be presenting on one of my favorite patients. For privacy reasons, I have him listed as the name Ted. Ted is a 67-year-old patient who came to the clinic in 2019. On the bottom, you can observe the condition of his teeth. His diagnosis was a history of heavy bruxism. When Ted first came to our clinic, he was aware that it would be a very long journey, but has been very patient throughout the entire treatment plan. His treatment has been 4 years in the making, so I'd like to highlight and thank the resident doctors who have all been part of the journey. Dr. Mohammadi created and initiated Ted's treatment in 2019. From his existing dentition, our working treatment plan was to eventually end with an implant retained denture and a number of implants and crowns on the bottom. Dr. Vishai continued his plan in 2020. This is the year of COVID, so treatment did get cut short. However, she was able to complete some work for Ted, including extracting all maxillary teeth and fabricating a temporary denture for him. Dr. Wong deserves a lot of credit for her work last year, so thank you, Dr. Wong. From 2020 to 2021, Ted had a number of his mandibular teeth extracted and eventually replaced with implants. Dr. Wong transitioned his maxillary temporary denture to a complete denture. So this brings us to this year. I've been given the honor to finish his treatment. This past year, we transitioned his complete denture to an implant retained denture while also placing 2 implant bridges and crowns on the bottom. We'll discuss the process in this presentation. Dr. Nguyen reviewed the next few steps in his presentation, so for sake of brevity, I will summarize the next few slides. My first task in Ted's case was to uncover the maxillary implants. Here, we can see the progression of uncovering the implants. Once his implants are uncovered, we can begin the first set of impressions. Our implant level impressions provide us with the lab information about the size of implant locators needed. Our next set of impressions is an abutment level impression that finalizes the location and position of our future abutments for our denture. So here, this illustrates a big milestone in our treatment plan. Here, you can appreciate 3 years of hard work. This has been a collaborative effort between both fields of periodontics and prosthodontics. 2 teeth on the bottom, 22 and 27, have had crown lengthening procedures completed. From here, we can work to complete his treatment. We have to acknowledge and address 2 major factors that contribute to our treatment plan. With a history of bruxism, while also needing multiple implants and restorations, how do we achieve a functional and stable occlusion? In order to not let history repeat itself, we have to do 3 things: verify occlusion, establish occlusion, and then maintain occlusion. Our first goal is to verify his occlusion. Due to a history of bruxism, his bite began to collapse over time. This gives us a very limited space for his mandibular restorations. The Stern Gold Detachment Gauge is shown here. It's a tool that measures precisely how much space we have for each arch. While adjusting the space on the denture, we completed multiple try-ins provisionals of the mandibular restorations to record and adjust Ted's occlusion in space. Once his occlusion was verified, we have the precise measurements that allow us to process and finalize his prosthesis and restorations. So now we are ready to deliver the final products. To recap, our treatment plan is to finalize with a maxillary implant retained denture, 2 implant bridges, and 2 crowns on the bottom. Here are some images of the final denture and restorations before the delivery day. With the previous steps of verifying occlusion and our work to communicate with the lab, we delivered both upper denture and lower restorations in one morning. The adjustments were very minimal, and the patient was very happy with his new teeth. However, our work does not end there. Since Ted has a history of bruxism, especially at night, it is very important that we are able to maintain the work we just accomplished. At night, when Ted isn't wearing his maxillary prosthesis, his implants will contact and wear against his mandibular teeth. This image was only taken a few weeks after his delivery appointment, and you can begin to see a small spot of silver on that implant where the gold has already begun to rub away. In order to address this issue, we fabricated 2 types of bite splints for Ted to wear at night. The maxillary bite splint covers each implant while having an embedded ramp. The mandibular appliance is a Brux Easy splint that is easily adjustable and can be warmed up to be placed. While wearing both, the ramp allows for a space that can guide against the mandibular appliance to protect both upper and lower. And after 4 years of hard work, we are finished. Not only are we lucky to have 4 resident dentists during this journey, but we are very lucky to have a great patient who has worked through us with this plan. I'd like to thank all those who have helped me on this journey, all the faculty and staff and attendings, and also my co-residents. Thank you all for making Kansas feel like home.
Hello, I'm Dr. Casserly. Thank you all for taking time to watch our presentations tonight. A little background on me: I was born and raised in St. Louis, Missouri. I went to college at Truman State University, where I played soccer, and then I moved on to dental school, where I attended UMKC. I decided to come to Wichita State's program due to all of the wonderful things I had heard about it from faculty and mentors at UMKC. I've decided to stay in Kansas after this program and serve the community of Lawrence, Kansas in a private practice office. I'm very excited to be going over one of the advanced cases I had the privilege of working on this year in the clinic. The name of this presentation is Full Arch Reconstruction with Orthodontic Intervention. I did this on a full maxillary arch after the patient had gone through orthodontic treatment to create restorative space. At the beginning of residency, I had the opportunity of finishing up the back half of a full arch case that legacy resident Dr. Keck worked on last year. These photos are showing the patient before and after her full upper arch reconstruction. In this presentation, we will delve into how to get from start to finish in a case such as this. The patient I had a chance to work on was a 50-year-old female. She was seen for a new patient exam by Dr. Keck, and these photos were taken at that initial appointment. Her chief complaint was that number 8 and number 9 were too big. Patient previously had bulimia. You can see in the photo on the left, number 8 and number 9 crowns are oversized to fill in a diastema. You can also see how we will be fighting for space in the anterior region when restoring this case. Here's an occlusal view of the lower arch. Overall, there was no restorative work that needed to be done. You can appreciate the attrition of the anterior teeth due to the lack of overbite and overjet. Here's an occlusal view of the maxillary arch. The patient has significant wear on the lingual of her maxillary teeth, and the dentin is exposed. The wear is so severe that lingual reduction is not needed during the crown preparations. Patient was informed by Dr. Keck that orthodontics would be needed to gain space for the restorative material. It was also decided that the patient's video would need to be opened. The challenge of this case was that the patient preferred short appointments, so during planning, we broke the case up into smaller segments. Here's a side view. You can see how there's no overbite or overjet present. This is why orthodontics will be needed to move the mandibular teeth back to gain more space. At first, we had to ask ourselves why there was so much more wear on the maxillary teeth versus the mandibular teeth. Bulimia had a large role to play in this, as the mandibular arch is less affected from the condition due to the tongue and salivary glands. Likewise, we noted that number 8 and number 9 had defective restorations, and abrasion also played a role in the patient's situation. Before the final restorations, we will have 2 sets of provisional restorations as a trial period for the patient. In addition, it was decided to not restore the second molars with crowns, so occlusal stops will be created out of composite on the occlusal surfaces of teeth number 2 and 15. Throughout the process, I explained to the patient that further treatment might still be needed, such as root canal treatment on certain teeth. After communicating our restorative needs with the orthodontist, the patient went through Invisalign treatment over the course of 5 months. The picture on the right is showing the patient after going through treatment. A big thank you to Dr. Hansen for his help on this case. You can see now that there is overbite and overjet present now, and we can move forward with restoring the upper arch. Here are some photos during the process of preparing the teeth. Originally, we were questioning the restorability of number 8. Upon removing her existing restoration, there was enough tooth structure left to build up this tooth. We worked in 3 sections at 3 different appointments. The first appointment, we prepped number 3 through 5. The second appointment, we prepped number 12 through 14. And the third appointment, we prepped number 6 through 11. In between each of these appointments, the chairside provisionals were made at her existing VDO. The provisionals were not made at the increased VDO until all of the teeth had been prepared. In this photo on the right, you can see the uniform axis of preparation, which is very important consideration in a full arch case. The final step to prepare for the restorative work was to prep the model to see what achievable reduction there was. Then we had the lab create a wax up at the increased VDO. We were able to use this wax up to make matrices for our first set of provisional crowns that we made chairside. Originally, we had lab temps created for number 3 and 14. The vertical was open too much, and the patient had a slight anterior open bite. After adjustments were made, as seen here on the right, new casts were sent to the lab. The lab was then able to refabricate the digital wax up to the new vertical. This is the matrix that I was just talking about, as you can see here. We use this to fabricate the set of chairside provisional restorations at the increased VDO, once number 3 and number 14 already had the lab temps. So why 2 sets of provisionals? Our first set of provisionals was made in our clinic using the matrix that you just saw. These were at an increased VDO, and though they are less aesthetic than the lab-made provisionals, they get the patient used to their speech and occlusion at the new VDO. The second set, as seen on this photo, came from the lab after taking full upper arch crown impressions, and they are more aesthetic than the first set. During the time she has these lab-made provisionals, she's able to find out anything she might not like about the aesthetics in speech. After all of this, we brought the patient back for a full upper arch impression for the full set of lab-made provisionals. We ended up re-impressing the first molars along with the rest of the arch and replacing these with new lab temps. After taking the first full upper arch impression and sending it to the lab, we received the lab temporaries. Here are some photos showing the aesthetics of these temporary restorations. During this appointment, I equilibrated the full arch of lab temporaries. At this point, I added the one-surface composite restorations to the molars as seen on the top left. This provides us with stable centric stops. We also needed to verify CR and communicate this with the lab. To verify CR, we used green occlusal wax as seen on the right and looked for areas of burn through, as well as using shim stock to feel the pressure distribution. Once we were able to verify equal occlusal distribution, we took alginate impressions to send to the lab to communicate the changes we had made. Here's a final photo of the lab-made temporary restorations. The patient was really pleased with the aesthetics and wanted the shade to be slightly lighter for the final crowns. Her speech wasn't affected at all by these new crowns. For the final restorations, we split the impression up into 2 separate appointments to have shorter appointments for the patient. We started by focusing on teeth number 6 through 11. As you can see here are before and after photos of the patient's smile. The photo on the right is the patient with final crowns number 6 through 11. We decided to have teeth number 8 and 9 splinted together due to tooth number 8 being a weak root canal treated tooth. The patient will be finishing up treatment soon by impressing the posterior teeth and delivering the remaining final crowns. The patient was very happy with the results and cannot wait to show all of her family and friends. Thank you to all the faculty, staff, and dental assistants that have helped me and guided me this year. A big shout out to my co-residents. I have learned a lot from each and every one of you and have grown so much as a dentist and a person throughout this year. Thank you for your time.
Hey everyone, I am Dr. Jonathan Nguyen. Today I am going to present on implant retained over dentures. The theme of my presentation will be building a solid foundation to obtain a predictable, well-fitting prosthesis. Throughout this presentation, I am going to share some tips on how I was able to successfully deliver some maxillary implant retained over dentures for my patients. A little bit about myself. I am born and raised in Houston, Texas. I recently completed my dental school education at Roseman Health Science University in 2021. In the white circle on the right, that is my school overlooking the gorgeous, majestic mountains in the background. My main hobby is trying new taco trucks everywhere I go. I've attached a screenshot of what my content looks like. If you haven't followed me yet, go ahead and follow me on Juan Listen Tacos on Instagram for more reviews and content. Why WSU AEGD? I had the opportunity to come to the WSU clinic 3 months before my interview and was impressed by the work the residents were doing, the facility, and the support of the faculty and staff. From that visit, I was confident in my decision and wanted to come here to further my training. On the right is a picture from our team serving the community of Hays, Kansas during the Kansas Mission of Mercy event. Over the course of the year, I have been able to learn a lot from our co-residents and mentored by amazing, experienced faculty. Living here in Wichita has made me appreciate the culture of the Midwest. It truly is a hidden gem that not a lot of people know about. With my year of residency coming to an end, this is without a doubt the best decision I have made. Go Shockers. Remember the theme of building a solid foundation to obtain a predictable, well-fitting prosthesis? Our foundational steps will be to create a diagnostic denture, take accurate implant level impressions, as well as accurate abutment level impressions. On the next slides, I will be talking about some common problems that is pertaining to the flyer on the right. I've indicated arrows on the concepts that I will be discussing. Some of the common problems we would like to avoid includes having the abutments either too high, too low, or having the wrong angulation. If the abutments are too low, it will cause an ill-fitting denture. The overdenture can be loose, it may move around, it may not be tightly secured to the implant abutment. In the middle, if the abutments are too high, then this will show through into the denture, which makes the denture too thin. This can cause the overdenture to become weak and potentially break. The wrong angulation abutments will prevent the overdenture from being as durable as it could be. Due to the different angulations of the abutment, this may have caused the denture to have weak spots in certain areas. We want to avoid these steps so that we can obtain a predictable, well-fitting prosthesis. Our first foundational step is to create the diagnostic denture. This gives us the ability to maintain the patient's vertical dimension and occlusion, and we will be able to use this as our custom tray as our open/closed hybrid implant impression. This is important because it is an integral step in the selection of our locator abutments in our implant overdenture process as we progress further. We create this diagnostic denture by placing the patient's current denture into a container, molding each side with the impression material of your choice. I used medium body here, and we filled the negative space with acrylic material. Once the acrylic hardens, you now have your diagnostic denture. Here's another look at the diagnostic denture we made. I removed a portion of the acrylic on the front of the denture as shown in the picture. Removing this will allow us to fully use this hybrid open/closed tray for our implant level impression. Again, this will be important to select the correct locator abutment heights in the later slides. 6 months later, after placement of the implants should be fully osseointegrated with the bone. We are now ready to uncover. I would like to quickly thank previous legacy Dr. Soma for passing the torch and entrusting me to continue this case and finish it to the end. Dr. Soma was able to place the implants and provide the surgical guide for me. With the surgical guide provided by Dr. Soma, we used a Thompson stick to mark in purple where the implants are located. On the right, we are using the biopsy punch hole to uncover the implant. Here, where the arrows are, you can appreciate how much keratinized gingiva tissue, also known as KG, is present. KG provides stabilization to the periodontium, which makes it favorable for us to use the biopsy punch method to uncover the implant. Some positive attributes of KG is that it forms a functional barrier to the oral environment, which can also protect the implant from external trauma. Once we are able to visualize the implant, we remove the implant cover screw and replace the healing abutment as shown on the right photo. This healing abutment will serve as a way for the tissue to heal around so that we can attain a nice emergence profile. 2 weeks later, after the tissues are healed nicely and nicely contoured, we are ready for implant level impression. We remove the implant cover screw and replace it with the healing abutments as shown on the right photo. This healing abutment will serve as a way for the tissue to heal around so we could attain a nice emergence profile. 2 weeks later, after the tissues are healed and nicely contoured, we are ready for implant level impressions. Our second foundational step is going to be the implant level impression. To prepare for this, we remove the healing abutments and insert the impression copings, which is pictured above. We will now use the diagnostic denture that we created earlier. Removing some of the acrylic in the front portion of the diagnostic denture allows space for the impression copings. We used a clear sheet of wax for the impression material to flow through. After the impression is taken, we will remove the impression copings and place the healing abutments back on. Once we send this to the lab, they will now have an idea of how to size the width and height of the locator abutments. This page has a variety of different size and height of the locator abutments. Communication with the lab is a very important step to prevent having abutments that are either too high or too low. We delegate this obligation to the lab so that they can choose the correct size for our locator abutments. Once we send our implant level impressions to the lab, they would choose the correct size of the gold locator abutments. We would then remove the healing abutments and place our locator abutments back on. This will allow the overdenture to attach or detach from these abutments. Our last foundational step is to obtain our abutment level impression. The lab will provide us with a custom tray to capture the abutment level impression. We accurately took this abutment level impression using medium and light body impression material. This is one of the old ways to deliver an implant overdenture. The way WSU AEGD has taught me is to systematically follow the foundational steps so that we can avoid light carrying the abutment chair side. Therefore, it is important for us to take the abutment level impression. Avoiding this method will allow us to have a stronger, predictable, well-fitting overdenture. To summarize what we have done so far, our foundational step in creating the patient's diagnostic denture, implant level impressions, abutment level impression, and constant communication with the lab, we are able to prevent any type of guessing where the abutments could be too high or too low. Performing these key steps has given me a solid foundation to successfully attain a predictable, well-fitting prosthesis. Here is one of my successful Metzler implant overdenture delivery case. You can appreciate the before and after and how much more vibrant this patient's smile is. The next one is also another successful Metzler implant overdenture for this gentleman. Both are very happy with the comfortability and durability of this overdenture. I would like to thank each and every doctor that has mentored me, the amazing assistants that has helped me every day, and the faculty that keeps the program running. Thank you, everyone.
Hi, I'm Dr. Zach Vogel, and the title of my presentation is Immediate Implant Placement in the Aesthetic Zone. I'll be discussing the immediate implant placement procedure and how with proper planning it is a tool to set a foundation for an aesthetic definitive restoration. So a little bit about myself. I'm originally from Cape Girardeau in southeast Missouri. I went to undergrad at Truman State University and completed dental school at UMKC. I came to Wichita State AEGD at the recommendation of many of my UMKC professors to expand my clinical skills and to be mentored by our faculty. In my free time, I enjoy spending time outside. Some of my hobbies include sailboat racing, skiing, and backpacking. So let's get started talking about this case. My patient, we'll use the name Christy, came to the clinic with a chief complaint of, "My front crown broke and I am interested in an implant." Christy had an Essex retainer with her with the remnant of the crown in its space and was looking for a more permanent option. After performing an exam and reviewing treatment options with Christy and the attending faculty, we thought that Christy would be a candidate for an immediate implant. In this procedure, a hopeless tooth is extracted and an implant is placed into the socket at the same appointment. Among the benefits of this approach is the ability to preserve the facial bone and gingival margins to obtain the most aesthetic, restorative result possible. We reviewed the treatment plan with Christy and received consent to proceed with planning the case. So the goal with planning this case was to begin with the end in mind. Using data from Christy's CBCT and a scan of her diagnostic cast, I designed the location of her final restoration based on the locations of her natural teeth, gums, and bone. These steps are shown in the pictures on the left. From there, I worked backwards to design the location of her implant based on the proposed restoration, as shown in the upper right photo. All of this information was then used to fabricate a surgical guide, which would help me to place Christy's implant in the exact location I had planned it. This guide is seen in the lower right photo. On surgery day, the first step was to carefully extract the root of number 9. The goal here was to preserve all of the thin buccal bone overlying the root and to minimize trauma to the gingiva. Thankfully, the root came out smoothly without any complications. The next step was to create the osteotomy, which made space within the alveolar bone for placing an implant. I used a combination of a guided and a free-handed technique. The surgical guide from the digital implant planning design provided the precise angulation and depth of my pilot hole. In addition, a guide pin was used and a radiograph was taken to confirm accuracy of my osteotomy. We now basically have a space within the patient's bone, the exact size of our implant. In addition, a bone graft was required in order to preserve the extraction socket and minimize recession during healing. The challenge here was to pack graft material into the socket without filling in the osteotomy we had just made. How this got accomplished is shown by the diagram on the bottom left of the slide. In the left image, we were looking from the side at the conical socket and the straight osteotomy below it. An osteotomy drill the same size as our implant, which is the gray bar in the second image, was placed into the hole. Next, the bone graft, red in the third image, was condensed into the space surrounding the drill. Finally, the drill was very carefully teased out, and we were left with a condensed bone graft along the walls of the extraction socket and a cylindrical hole for our implant. So now we are ready to finally place our implant. A 13 millimeter implant was placed to depth, passing through the bone graft, which was then repacked around the implant. Because of our planning and design, this part of the procedure went smoothly and predictably. Here's an additional photo of placing the implant as well as a radiograph. The next step was to make a custom healing abutment, which will help preserve the shape and contours of the gingival anatomy as they were prior to extraction of number 9. A temporary abutment was placed, and flowable composite was cured at the gingival crest to capture the gingival margin of the extraction socket. On the lower right, you can see what it looked like once I removed it. This thin shell of composite is the same shape as the cross-section of the extracted root. I then used flowable composite to build up and shape the abutment. I wanted everything to be smooth and concave all the way from the gingival margin down to the base of the abutment where it meets the implant. My goal here was essentially to create a root-shaped healing abutment. Once I was happy with the custom healing abutment, I reseated it and tightened it. White Teflon was packed into the access, which was then sealed with composite. The excess portion of the abutment was then trimmed and smoothed flush with the gingiva. The two bottom pictures on the screen show the completed custom healing abutment. Notice how the abutment mimics the root that was extracted. The final step of the appointment was to modify Christy's Essex retainer so that she left with a temporary front tooth. I used composite to veneer the facial and incisal aspects of number 9 to ensure it did not contact the custom abutment, and then confirm the retainer could fully seat. Christy was very happy with the temporary front tooth. So here's some before and after photos taken on surgery day. On the left, you can see the root of number 9, and on the right, you can see the implant and custom healing abutment. Because of our implant planning and surgical design, we were able to complete the procedure predictably and efficiently with very minimal trauma to the patient's anatomy. I saw Christy 1 week later for a follow-up. She reported no post-op complications and that she was very pleased with her experience. The surgical site appeared to be healing well, and the gingiva surrounding the custom healing abutment was pink and healthy. The picture on the right is from the follow-up appointment. So far, the gingival anatomy surrounding the implant has been preserved. At the time of this recording, we are waiting for osseointegration to occur, and the next resident will move forward with Christy to fabricate her definitive restoration. I'd like to wrap up by thanking my Wichita family. A special thank you goes to Dr. Jason Wagle for his guidance and for working with me on this case. I'm grateful to each of the faculty, assistants, hygienist, and front desk team for their support, patience, and mentoring this year. Finally, I want to thank my fellow co-residents who are some of the most amazing people I know. I'm a better dentist in person because of Wichita State AEGD, and I'm truly grateful for this experience. I'll be moving to the Kansas City area to begin working as an associate dentist, and I'm looking forward to taking the skills and knowledge I've learned this year to help the patients of that community. Thank you.
Hello everyone, my name is Dr. Jay Bhakta, and the title of my presentation is A Potpourri of Occlusion Techniques. So a little background, I'm originally from Liberal, Kansas, the southwest corner of the state. I went to undergrad at the University of Kansas. I'm a very proud Jayhawk alum this year due to winning the championship, Rock Chalk. I attended dental school at UMKC School of Dentistry. I graduated last year and I am attending the WSU AEGD program right now. I decided to come to this program due to hearing very good things about this program from all the mentors at UMKC. There's a strong group of faculty here. That's one of the main reasons why I chose to come here. And also, the majority of my family lives in Kansas, so coming to Wichita to advance my dental education to the next level was a good move for me. Fun fact, my wife is a dental assistant, and she actually had the privilege to work with us this year. The main theme of my presentation consists of cases that deal with the exciting topic of occlusion. So we are going to cover when to increase video, when to decrease video, and how to make MIP coincide with CR. The first case I'm going to be presenting is one dealing with increasing video. This patient had the chief complaint of wanting to chew again and eat again. He was not interested in implants. He was at an age where he did not want to spend a Cadillac amount of money on his mouth trying to rehabilitate it. Truly, he just wanted to be able to chew again. The teeth were solid and nothing can replace natural teeth, so we went on about fabricating a removable prosthesis. Taking a look at this patient's bite, you can deduce that a traditional partial would not fit this patient's current bite. So we had the lab fabricate a framework. One thing to note with a big framework, there are a lot of contact points in the mouth, so there is increased chance of it not seating. The tip here is to use disclosing wax, and don't confuse this with PIP paste. This wax is faster to use and it doesn't smudge. You want to keep the RPD dry so the wax sticks to it, and the teeth wet so the wax doesn't stick to the teeth. The probe is pointing to a space where the RPD is not fully seated. So after trying it in the mouth, you will see pressure points where the framework is binding, and you can adjust accordingly. You can adjust it until it's fully seated and have the lab process it in order to open the bite. So what the lab did here was they overlaid the posterior teeth with metal crowns and they veneered the anterior teeth. With frameworks this complex, it can be done, but you have to realize that these aren't regular denture teeth. You have to be aware of lab surcharges for a partial this complex. The veneered teeth in this partial are a little bit lighter due to the patient wanting to match his existing PFM crowns. Here's the result. He was very happy to finally grill up a piece of steak and eat it, in pieces of course. And this was a neat case to be a part of due to it being one of our faculty, Dr. Carnahan's friend. The second case I will be presenting is one dealing with decreasing video. The chief complaint of this patient was she could not wear dentures that were made for her. You can notice how big they look in her mouth. Her mouth looks very full and she was not able to make any use of them. The main problem here was freeway space, and there was about 10 millimeters of it. We noticed her teeth touching during her speech. This indicated that there was too much teeth and not enough space for speaking. We took some measurements with and without her dentures and found out that the formula that we learned in our first denture course in school, VDR minus VDO, was supposed to be 3 millimeters. It was incorrect. In fact, it was reversed, and it ended up being 10 millimeters. So if we plug in these numbers to the formula, the difference we got was a negative 10 millimeters when it should have been a positive of 3 millimeters. Now that we know the problem, we instructed the lab to close the VDO. Now that we got the dentures back from the lab, we were ready for the first wax try-in. The formula now was correct, having a positive 3 millimeters of freeway space, but now the patient-centric relation bite was not correct. We were able to guide her lower jaw into CR, but we had to relay this information to the lab. This brings me to the third point of my presentation, how to make MIP coincide with CR. This is when a central bearing device comes in handy. Not many know this, and labs do not openly advertise this as well, but you can request it from the lab in order to accurately record the bite of the patient. The goal is to record the retruded position of the mandible. We had the patient move the lower jaw forward, backward, side to side, but the point we want to communicate with the lab is the mandible in the retruded position. It's important to note that we do not want either of the arches to contact each other. This will give a relation based off the teeth that are set, and this is incorrect due to CR being a jaw relation, and this is what we're trying to obtain and communicate with the lab. From this, the lab will be able to reset her teeth where MIP and CR coincide, and this resulted in the second wax try-in, which was a success. The patient was so happy she was able to wear them comfortably, and she was almost in tears. Finally, some acknowledgments I have. For the faculty, there are strong mentors with tons of experience to share. They never belittled us due to our lack of knowledge. They were available chairside during complex procedures for support. Secondly, the assistants. They're the arm and legs of the program. We couldn't do anything without them. They also have a lot of tips and tricks to share from their many years of assisting. They provide motivation during tough and new procedures. Finally, I want to thank my co-residents. It was awesome getting to go through this program alongside each other. We all came from different backgrounds with different experiences, and we got to share that amongst one another and collaborate. We've come a long ways right outside of dental school, and I feel prepared to take on the real world. My next steps are that I'm happy to announce that I'm actually going to be starting a career and practicing in Salina, Kansas. I'm excited to have the opportunity to provide care to the people of Kansas for the years to come ahead. Thank you.
Good morning. My name is Dr. Seth Sherwood. I'm one of the 6 residents here at the Wichita State University AEGD Clinic. For the next few minutes, I'm going to talk to you about an exciting case I had the opportunity to complete during my year here. A quick background on myself: I'm a graduate of the Wichita State Dental Hygiene Program, and I got my DMD from the University of New England in gorgeous Portland, Maine. I'm a huge Dallas Cowboys fan, and I've been doing woodworking for a few years. The most important thing in my life, and the reason I do it all, is for my baby girl Emerson, who was born last September. Today, we're going to talk about patient history, the lower arch, the upper arch, and denture fabrication. So patient history. As I mentioned before, one of my passions is woodworking, and at first thought, you may think dentistry and woodworking have little in common, but in fact, they have many of the same challenges and rewards. Today's theme is about creation and transformation. I picked up this case from last year's resident, Dr. Lucy Swisher, who first saw the patient in October of 2020. During her comprehensive exam, the patient noted that she thought all of her teeth needed to be extracted and that she did not want anything removable. Here's a picture of our patient in her 40s and another picture of her at the time of the comp exam at age 76. As you can see, she presented with years of neglect, rampant decay, collapsed VDO, thinning ridge on the upper left, and buttressing bone, which is thought to be a sign of traumatic occlusion. The panoramic gives another perspective for the general overall picture. Based on the available documentation, I believe Dr. Swisher was justified in her treatment planning decision to extract all of the teeth, and followed by implant placement and overdenture prosthesis. So let's talk about the lower arch. In November of 2020, Dr. Swisher removed all of the teeth and performed socket preservation with bone grafting and resorbable membrane. Here are the photos from the time of the follow-up. which the patient had been wearing her interim for about a month. So we've cleaned everything up, we've removed the disease, and we're healing nicely. In June of 2021, Dr. Swisher placed the lower 4 Nobel narrow platform implants using a guided placement protocol. In this image, we have the lower implants placed subcrustally and cover screws are on. Here's a great image showing the lower implants were placed wonderfully by Dr. Swisher. They're subcrustally and parallel, and a very good result. At the 2-week follow-up, you can see we don't quite have primary closure, but we're getting very close. You can see the shadow of the cover screw in the number 26 or number 27 position. At this stage, the case was handed over to me, so we finished the lower arch and we're ready to move on to the upper arch. I want to briefly talk about digital anesthesia. This is a method to control the flow of anesthetic into the tissue and provides an almost painless anesthetic pathway. And it reduces the amount of medicine needed to produce profound anesthesia. So far, anecdotally, I've had 100% of my patients say that they prefer this method to traditional manual administration. During our simulated surgery, using our implant planning software, we knew we were going to have a challenge due to the bird beak shape of the maxilla. As you can see, there's very little room for error. Starting on the right side, we decided to do a tissue punch method rather than a flap due to the amount of kg present. Notice the stabilization pins ligated with knotted floss. Pins, however, are not perfect as they still allow for a small amount of float from the guide. After placement, we noticed a facial perforation of number 6 due to the bird beak ridge. Normally, we use a sinus probe to feel for perforations in the Schneiderian membrane, but it was used here to get a tactile sense for the bony walls of our osteotomy. We made the decision that no implant would be placed in the number 6 site. Here we have sutures after closure. 2 more Nobel implants were placed on the right side in the same fashion. While 4 is optimal, 3 implants on the upper will provide stability and retention for a palateless upper denture. Here's the final pano with all 7 implants placed. So a stable foundation has been laid and we're ready to start restoring some functionality. Here we've uncovered the implants and placed our corresponding narrow platform healing abutments. Sutures were placed to assist in the anastomosis of the margins. Modifications to the interim had to be made to account for the healing abutments. This also helped with retention and stability of the interim denture. So moving on to overdenture fabrication, we're starting to see the bigger picture come together. In cases like this, we're dealing with a lot of small parts and pieces, so one method I use to organize everything is to place 2 arches of wax and label them with the unique identifiers where your parts will go. Here we used a closed tray method for our impressions. Another good practice is to have your parts tied with floss for easy retrieval if dropped, as well as a piece of wax on the end of the driver head so that the parts stick to it. Here we have our locator abutments and hater bar on the lower. The fit was great and the tissues are looking healthy. We have very favorable band of keratinized tissue. I absolutely love this picture. This is a real photo from this patient and it shows the revascularization of the tissue as it's mended around our healing abutment. You can even see the 3 distinct layers with striations in the sulcular epithelium and the erythema of the connective tissue that had previously formed a hemidesmosomal attachment to our healing abutment. At the wax try-in appointment, the patient gave an unprompted Duchenne smile for the first time since I've known her. I really wish I would have been able to capture that on camera. And finally, here's the final result. Upper and lower implant retained overdentures with mandibular bar, upper locators, and a palateless upper denture. So that's all from me. I really hope you enjoyed the presentation and maybe you've learned something. I want to thank all of the faculty and assistants who helped along the way. This would not have been possible without your confidence and support. Thank you.
Good afternoon. I'm Dr. David May, and I have the privilege of serving as one of the part-time faculty in our AEGD residency. First, I want to offer my sincere congratulations to our graduating resident class of 2022. It's been a good year. I would like to speak for a moment on the value of postgraduate dental education. Dentistry is highly complex, and it's very difficult to learn it all in 4 years of dental school. So, first of all, the value of this year is a year of discovery. It exposes the residents to new concepts, new procedures, and new technology. In addition, the residents discover their clinical preferences, their likes and dislikes, and certainly their skills and limitations. Secondly, this year is a year of transformation. Each year, our faculty observes much professional growth, maturity, and confidence. And this is what encourages us to do what we do. And finally, this year is a year of preparation. Our faculty's desire and purpose is to better prepare each resident for their journey ahead and to be a lifelong learner through continued professional education. Residents, we are proud of each one of you, and once again, congratulations.
Hi there, my name's Brandy and I'm one of the hygienists here at WSU Dental. I first of all wanted to congratulate all of the residents I've had the privilege of working with this past year. It's been wonderful watching all of you guys grow as individuals and as dentists. I'm very excited to see you guys all go into your next chapter. And I'd also love to congratulate and welcome the new residents here. Me as your hygienist, I am here to answer any questions that you may have about periodontal disease. And I'd also love to be able to be a part of your questions for dental hygiene diagnosis. I'm also going to be here to help you be better prepared for the future with how to work with a hygienist, such as when you come in to check your dental exams, I will be there and I'll kind of set up the report with you guys by introducing you to your patients and also pointing out any areas of concern so you have more of an idea of what to do. I'm excited for you guys, and you guys are walking into a very healthy and upbeat environment where you have tons of growth potential and it's a very relaxing environment. Thank you, and I'm very excited to get to know you all.
Hi, my name is Machen Johnson. This is my first year with WSU General Dentistry as the dental clinic manager. I come with 10 years of dental experience, both clinical and administrative. This was the perfect time for me to join WSU as they've invested in the latest dental technology. I'm thrilled to be able to contribute my experience and ideas as we go through this journey together. They now have a CEREC Prime scan, so we can offer patients one-day visits for crowns. We have our Sprint Ray 3D printer, GoPros, and the newest radiology equipment. With all this technology, our residents are receiving the most modern-day dentistry experience, as well as sharpening their skills to become the greatest in their field. I'm truly grateful to have onboarded with this year's residents. We've learned so much from each other. And because of their inquiries and practice management, we now have a dental business course that will be taught once a month. We'll explore all the operations behind the front desk, from accounting to insurance. I wish them all the very best in their dental careers. I know they'll all do well. And I look forward to meeting the new residents as they begin their journey with us. Welcome to Wichita State.
How's it going? I'm Caleb Murray. I'm from Columbia, Missouri originally and went to school at UMKC Dental School. I chose this program for a number of reasons, the biggest of which is definitely the people. Dr. Elledge is just great, except when he makes us record this video so many times. Amanda is awesome, always on top of it. I know there's so many other faculty we're gonna get to know, get to spend time with. Really excited about this year to be working with a great group of co-residents and just to get to be able to do a lot of stuff, a lot of general dentistry. I want to get good at just the normal private practice stuff that everyone does. So I'm also excited to be placing some implants. So I think it's going to be a great year.
Hi, my name is McKay Jensen. I came from Riverside, California. That's where I grew up, and I went to dental school all the way on the East Coast and at Virginia Commonwealth University. So smack dab in the middle is the perfect place, Wichita, Kansas, at the AEGD program here. And I chose this program because of the quality group of experienced faculty, and I hope to walk out of here with greater skills in dentistry and as a better person to be able to serve this community.
Hi, I'm Kira Powell. I'm from Findlay, Ohio, but I graduated from dental school at the University of Michigan. I knew I wanted to come to the WSU AEGD after my husband and I came here to tour the program. I knew it would be the perfect fit for us because everyone was so kind and welcoming, and I knew that I wanted to spend the year exploring Kansas and sort of doing our own little adventure here. I'm really looking forward next year to learning everything I can about Wichita and to meeting my new patients and getting to know my staff and my faculty.
Hello, I'm Tyler Powell. I'm from Saline, Michigan, and I graduated from the University of Michigan School of Dentistry. What stuck out to me about this program was just how welcoming and friendly everyone was here. It's just a really positive and comfortable environment. Dr. Elledge is really a character, fun guy to be around. Next year I'm looking forward to learning as much as possible from the amazing staff and faculty here and working alongside my amazing wife as a co-resident and my other co-resident and their families.
Good evening and congratulations to the AEGD graduates and to the new residents who are coming in to AEGD. Welcome. I'm sure it's not news to you that these graduate programs are critically important for advanced training of dentists, and we have a huge need for dentists, not only across the United States, specifically in Kansas. We have over 70 counties that are dental health deserts. We have over 20 counties where there are no dentists at all, and of the dentists in Kansas, only 25% see people who are on Medicaid. So particularly for children, for elderly, and for people of low income, getting dental care, which we know is critical for overall health, is very important and very difficult to get in Kansas. The residency program was designed not only to train residents, but also to try and get residents to stay in Kansas and practice after they finish the residency program. So for you who are graduating from the program, please think about staying, and for you who are starting the program, we'll continue talking about how to keep you here in Kansas. I won't take any more time. I'm very happy that you're here. For the graduates, we're so happy that you came. We hope you will spread the word about our residency program. Good luck to you, and good luck for the new AEGD residents who are coming in.